Good afternoon, everyone. Today's topic is RDS, respiratory distress syndrome. Myself, Dr. Priyanka Jain. We will discuss about RDS. What is this RDS? Anybody idea? The term RDS, respiratory distress syndrome, are most often applied to the severe lung disorder in neonate, which is primarily related to lung immaturity, more common in premature babies. It is responsible for more infants' death and neurological complications. Respiratory distress syndrome is a syndrome of premature neonates that is characterized by progressive and usually fatal respiratory failure, resulting from atelectasis and immaturity of the lung. It was formerly known as hyaline membrane disease (HMD). In this disease, the syndrome, breathing rate is usually more than 60 breaths per minute and or use of accessory muscle of respiration, which may be accompanied by grunting, alarmnesi, flaring of alarmnesi, subcostal retraction, accessory muscles involved. Surfactant production usually start around 20 weeks of life and peaks at 35 weeks. Therefore, any neonate less than 35 weeks is prone to develop respiratory distress. Without surfactant, infants are unable to keep their lungs inflated. Now, what are the predisposing factors? Most common: prematurity, asphyxia, hypothermia, maternal anemia, preeclampsia, maternal diabetes, cesarean section. Pulmonary risk factors like pneumonia, pneumothorax, congenital malformation, upper airway obstruction, example MAS, meconium aspiration syndrome. Non-pulmonary risk factors like sepsis, very common in newborn due to any cause, cardiac defect, any nervous defect, exposure to cold, temperature instability, hypothermia, hypoglycemia, metabolic acidosis, and acute blood loss, leading to very dangerous death. What is the pathophysiology of respiratory distress syndrome? In RDS, the basic abnormality is surfactant deficiency. Opposite protection is 28 people. It is lipoprotein contains phospholipids, reduced white type second alveolar cells of lungs and helps to reduce surface tension in alveoli. During expiration, when the child expires, absence of surfactant and surface tension increases, so follow alveoli collapse. During inspiration, more negative pressure is needed to keep alveoli patent. Due to all these conditions, proper inadequate oxygenation in the body, increased work of breathing, causes hypoxemia, estrogen, and severe hypoxemia. That is pulmonary vasoconstriction leading to right to left shunting across foramen oval. So causes worsen hypoxia, severe hypoxia, premature. And the patient will lead to respiratory failure, severe respiratory failure, depressed child into life-threatening conditions. Now, what are the clinical features? Is very commonly seen in newborn babies. Tachypnea. Tachypnea means less than or 80 to 120 breaths per minute. Dyspnea, pronounced intercostal or substernal retractions, fine inspiratory grunts, audible expiratory grunt, like that. Flaring of external layers. Cyanosis, bluey discoloration, peripheral or central or parent, severe anyway. Manifestations occurs as the disease progresses, like apnea, child becomes flaccid, absent spontaneous movement, like depressed child, unresponsiveness without any emphasis. Diminished breath sounds vibrator, mottling of the skin, and in severe condition, fog-like state. On picture, blue discoloration, the lips, that is central sinuses, mucous membrane movement, areflexia, depressed chest, sinuses, chest wall disease, suprasternal, intercostal, subcostal, increased movement of the sinuses. RDS, RDS, very important to make a diagnosis of RDS. We should take the immediately chest X-ray of the child. That is found in symmetrical ground glass. Ear bone, lung body, no. Now, what is this Downey score? Downey score. Downey's score like respiratory rate per minute. We see the cyanosis, retraction, grunting, tear. Respiration, respiratory rate per minute less than 60, that is 0 score. 60 to 80, that is 1, and 2 score more than 80. Cyanosis, nil in room temperature, but presented 40% given oxygen given to the child. And grade 2 is presented more than 40%. Retraction, none, mild, 1, and moderate to severe, 2. Grunting, none, 0 score, 1. Audible with stethoscope and down score, audible without. Clear increase, clear and down score, 0 grade, and grade 1 delayed or decrease. In grade 2, barely audible, very rare. Now management. What is the management? Medical management. Neonates suspected to have respiratory distress syndrome need to be treated. Very emergency at the time of delivery for premature. We should give IV fluids immediately and oxygen. Start oxygen therapy at least temperature for 6 liters of 1 minute. Maintain oxygen saturation between 90 to 95%. Administration of exogenous surfactant through endotracheal tube directly into the trachea, immediately without waiting. Now, what are the medicines? Most important role of antibiotic. So, what are the important antibiotics we should prefer? First of all, aminoglycosides, amoxicillin, ampicillin, otrimoxazole, and penicillin. Usually given for, at least we should give for 7 to Then muscle relaxation, like pancuronium, we can advise. Diuretics, like glutamate, and antacids like sodium bicarbonate, sodium citrate. Indomethacin, if patent ductitis is good, then we can give indomethacin without waiting. And now, what are the supportive management? Supportive management is having very important role to manage this emergency conditions. Maintain adequate hydration and electrolyte status. Very important. Administer antipyretic to reduce fever if fever is there. Maintain acid-base balance if any hyperlipidemia is like the acid-base imbalance is there. No lipid or kavas feed because of the chances of aspirations increase. The aspirity rate and chance of aspiration is also increase. IV line, fluid, hydration, and proper nutrition and medication. So IV lines should be clearly and not closed because to maintain the hydration, IV line should be immediately urgent medication for the spirit syndrome child in NICU. Nursing management. How to assist nurse by the nurses. Proper history taking, physical examination, Downey's score, score 0, 1, 2, respiratory rate, sinuses, grunting, 3 muscles, small, per minute. Physical examination down to safe test. Now, nursing diagnosis. Ineffective breathing pattern related to surfactant deficiency and elbow instability. Impaired gas exchange related to immature pulmonary function. Altered nutrition, less than body requirement related to feeding difficulties. So, altered nutrition. Because the baby, children with respiratory distress syndrome disease, the baby used to be unable to feed or very difficult to feed. Altered body temperature related to prematurity, parental anxiety related to disease condition, risk for injury, brain injury, severe hypoxemia, suppressed, depressed child related to that. What are the interventions we should do? First of all, we should assist preterm infant for respiratory and general status, like oxygen saturation, child oxygen saturation, cyanosis, ABG, axillary temperature, respiratory pattern. Maintain airway and administer oxygen 3.2 to 6 liters per minute. Provide ventilator support in case of need. Perform gentle chest percussion by the thumb, vibration, postural drainage, to assist need and abdomen. Monitor for sign of hyperthermia, flushing, tachycardia, altered level of consciousness, and hypothermia. Decrease activity, respiratory distress deterioration, mottled extremities. These are the common signs of the hyperthermia, usually found in children. Place the infant in radiant environment. Use environmental control. Warm well ventilated room. The room properly should be hygiene, ventilated. Air, maintain the air. So ABC is having very important for decreasing heat. Position the infant to facilitate open air on the side with head supported in hand by a small police seat. Position. Quick, gentle sucking, not more than 5 seconds. Suction is very important. Mouth and nose. First, we should suction. We should do suction of the mouth to avoid the aspiration chances, hypoxemia, and then we should do suction. The mouth suction followed by nose. Not more than 5 seconds. Fine catheter is needed. Placed in the face. Maintain neutral thermal environment to decrease metabolic requirement and to conserve oxygen utilization. Maintain parenteral nutrition. Avoid oral feeding or throat tube if child is in distress to avoid the aspirate. Maintain optimal nutrition pattern of the infant once baby is breathing without distress, registered feeding is done. Involve parent in the care of children and allow frequent visit to encourage and promote infant parent bonding. Skin care, the frequent position change, mouth care, psychological support, and provide adequate information about child's condition. Now, what are the complications? Complications of respiratory syndrome in children because leading the life-threatening complications like PDA, patent ductal fibrosis, congestive cardiac failure, intraventricular hemorrhage (IVH), retinopathy of prematurity (ROP), pneumonia, sepsis, necrotizing enterocolitis, neurological sequelae. Thank you.